Okay, I think we've achieved somewhat of a quorum this morning. Thanks for joining us once again in this particular edition of Innovations in Diabetes and Cardiovascular Health. Remember to not disclose any PHI in your case discussions. Here's the usual reminders about any help that's needed. And here's some basic information about cardio, which you've certainly seen before. This morning, I will facilitate as usual. Kathleen and Kelsey are going to tag team this one. They are going to talk about advances in telemedicine. We have two very interesting case presentations by Sarah and Amber, and Danette and I will be our discussants, but of course we'll open it up to the entire group as well. Here are our disclosure statements, no new disclosures that I'm aware of. And with that introduction, Kathleen, I think you're up first.
Thank you. Good morning, everyone. So we're going to be talking about advances in telehealth, and these are our learning objectives. You can review those. We'll be describing some recent growth in telehealth, how to prepare patients for a telehealth visit, and some of the evidence for benefits in the cardiovascular population. So what is telehealth? It means a lot of things and is defined differently in the literature, making it very difficult to actually do any kind of systematic search. But in general, it involves some kind of a communication between a patient and provider from two separate geographic locations. And originally in the Medicare definition, those two separate locations had to be a clinical setting, like a clinic or hospital. And of course, many of these restrictions were raised, at least temporarily, but we don't know for how long during the pandemic. And this is just one example of the rise in telehealth that occurred at the start of the pandemic. This is data from the VA health system. And we can see on the left panel is video visits, in particular mental health visits, skyrocketed. And other types, primary care specialty, also rose or at least doubled. And then on the right panel, you can see the phone visits also similarly increased, but notice that the order of magnitude is nearly tenfold more. So the success of telehealth in general was observed, but perhaps more so with telephone visits. And in terms of the impact on the patients and the providers, first, this is a survey that was conducted with primary care providers through a national representative sample. This was about a year or so after the start of the pandemic. And you can see in this graph, there are 3 time points: before COVID, during COVID, and after COVID. And if you look at the blue line there, the number of physicians who were using telehealth often was only about maybe 5% or so, rose almost tenfold during the pandemic, and then declined to steady levels of somewhere in the mid 20%. And likewise, those who had never used telehealth, more than 50% had decreased down to about 5% or so, and that remained about steady. And again, just to kind of look at from the patient side, this was a Trilliant Health report, which was conducted from claims database between the start of the pandemic and about almost 2 years after. And so only about a quarter of Americans used telehealth during this time period. 80% still received only in-person care, so we can imagine that there was a lot of missed visits. And 3/4 of physicians and almost 2/3 of patients thought it was more convenient for the patients. However, only about 1/3 of physicians found it to be more convenient, and we'll talk a little bit more about why that might be. And so Kelsey's going to take it over from here.
Thanks for getting things started, Kathleen. Yeah, as she said, telemedicine has really grown, and it has quite a lot of potential, both in terms of filling a need during the pandemic and going forward. However, there are some considerations for telemedicine appointments that might not be as relevant during in-person ones. For example, one of the big advantages of a telemedicine visit is that patients have access to specialists and healthcare resources that aren't available in their area. But on the other hand, that means providers cannot assume when they have a telemedicine visit that they're talking to somebody who lives within driving distance of their clinic. And so there might be different cultural considerations talking to somebody who lives somewhere very far from you and has a very different cultural context. Digital literacy is also something that is really of concern, particularly for older patients who aren't digital natives. Quite a few of them use their phones or their devices sparingly and aren't really comfortable with those, which can make a telemedicine appointment less attractive to them. And that can go for both the patient and the providers. As Kathleen said, some providers and some practices are more comfortable with and better set up for telemedicine than others. And one of the big concerns that patients have, which I found in a survey of telemedicine of primary care patients in 2021, one of their big concerns was the loss of in-person care and that relationship and rapport with their doctor. They just don't feel like they can get that in a digital setting. And of course, there is the whole issue of whether or not these patients even have good internet or a telemedicine ready device. Like, for example, if they have a limited data plan, which means that a telemedicine visit would take more data than they have, it's a no starter. Similarly, speaking with some primary care patients recently, one of their biggest concerns was whether or not a telemedicine appointment would be covered by their insurance. A few years back, me and some colleagues at University Hospital's primary care setting in Cleveland, Ohio, conducted a preliminary survey to figure out the telemedicine readiness and experiences of some older patients who were in the clinic to have an already scheduled appointment. All of these patients had some sort of chronic condition like diabetes or heart disease that could theoretically be managed via telemedicine. And we were asking them questions about, say, do you own a smartphone or computer? What sort of things do you do on this device? Have you had a telemedicine appointment before? What are your concerns about telemedicine, etc.? Next slide, please. And we found some pretty clear patterns. Nearly half of our patients owned a budget smartphone, so not an iPhone, which is relevant because a lot of video platforms that telemedicine runs on work better on an iPhone or a computer with its bigger screen and physical keyboard compared to a budget phone. And a fairly sizable portion of them had no device at all. The most common way these devices were used was for messaging only, and it's quite possible that this messages was just text messages, so they're not really using it for very interactive things such as emails or video calls, which would help them build the skills that would be good for a telemedicine appointment. And keep in mind that this is after the pandemic has been going on for about a year, but none of them are using their phones for things like shopping or online banking, which means that it's not really occurring to them to use their phones to manage their lives or to have a online substitute for an in-person activity. Next slide, please. We found that the patients who had a telemedicine visit had some pretty clear differences from the patients who had not. Those patients who had not had a telemedicine visit were obviously ones who were more likely to not have any device at all or to use their device in very limited ways, whereas those who had a telemedicine visit were more likely to have an iPhone or to have an email account. So people who have a bit more sophisticated devices and are more comfortable using them. Next slide, please. And there were also some pretty clear differences by age. Patients who were in their 60s were much more likely to have had a telemedicine visit and to be using it in a more interactive way, such as through email or to stream movies or do video calls, compared to patients who were 70 and older. So patients' age can often be a proxy for their level of familiarity and comfort with this type of technology. Next slide, please. We asked them a bit about what they thought the benefits and drawbacks of telemedicine were, and quite a few of them liked that the convenience of telemedicine. Nobody enjoys fighting traffic and everybody's worried about COVID, but they were worried about losing their connection with their doctor, and they were concerned about the care quality they could get since the doctor would not be able to lay hands on them or physically examine them. Our overall findings just suggest that, especially with patients 70 and older, they need greater technological help. Possibly for that age group, it might be better to have a more tech-savvy person arrange a telemedicine visit and manage the device on their behalf. But basically, people, even if they have an internet-capable device, you can't assume they're able to use it as much as they could. Next slide, please. Kathleen and I took a look at the literature regarding telemedicine, and we found that there's not very much out there comparing pure clinical appointments, such as an in-person diabetes managed appointment to a virtual telemedicine appointment. Although that literature is growing, it's much more likely for there to be interventions. For example, you might compare a program for the CDC's diabetes prevention program delivered in person versus delivered via video conferencing or via an online application. And as Kathleen said earlier, there's a lot of different modalities. You have telephone, you have the video conferencing, which is widely preferred, but it's newer than quite a few of the others. And sometimes different modalities are combined. For example, you might have one that has one-on-one counseling and then a group chat on other days. So it's very hard to make comparisons. However, most of these show that telemedicine can have a pretty good outcome, especially if it includes the same elements as a lot of the in-person appointments, such as getting patients to self-monitor. For ones that are related to weight loss, they usually include elements such as portion control and trying to encourage physical exercise. getting patients prepared for a virtual appointment. And this can be done either with somebody in the clinic or a family member who might be a bit more tech savvy, depending upon that person's availability and level of need. Generally speaking, it's recommended that you have the patient prepare their device beforehand. So have it charged, make sure the internet connection's good, not try to multitask on the device, and then tell them to concentrate on the appointment. So find a private area where they won't be interrupted, where the internet signal is good. One of the advantages of telemedicine is it can be done anywhere, but that doesn't necessarily mean it should be. So, for example, ask the patient to not try to have the appointment with you whilst driving their car. Ask the patient to prepare for the appointment like they would any doctor's appointment, such as have your questions ready, the medications. If they're keeping something like a log of their glucose readings or their blood pressure, have that ready. And if there's something that they would like to have their doctor examine, like a patient with swollen feet might want to have their shoes removed in advance. Next slide, please. And we'll send this back to Kathleen.
All right, thanks, Kelsey. So here are some of the major components of the telehealth team, and the way I view it, it should be similar to any in-person visit. So and really it's important to prepare prior to the date of the visit. So from the perspective of what schedulers ideally would be responsible for is to, when they're scheduling, is to review what types of expectations that the patient might have in terms of devices and just experience in general. Providing them with logs or device-specific instructions, and then after the visit, contacting the patients. And then in terms of the nursing staff, a pre-call reduces the chances of having a failed video visit. So you saw all that data where patients were primarily, in large part, managed with telephone visits. If you just do a pre-call, that can help a lot because they can do tech checks, they can do the medication reconciliation, and update the chart with any other kinds of health maintenance information, and also help get the glucose monitoring data if not already. And then the rooming itself, technically you could also do that, but I've found that it's not necessarily it's not absolutely necessary. I think it would be nice though to at the time of the visit, having someone help with the same types of last minute issues. But the softwares that are available now will actually facilitate pre-rooming. So the patient's not just sitting out there in the middle of nowhere waiting on a call when you're running late. And then using some type of strategy to track the progress of all the information and steps, as shown here in this kind of mocked up example. So you can change the status of the patient if they've not been contacted, if they've been roomed, but maybe you don't have the data you need, those kinds of things, and then how to contact the patient. Next slide. And in terms of diabetes, which I have the most experience with, I think it all begins well before you actually ever do a video visit. So in terms of putting a patient on a device like a continuous glucose monitor, you want to have ideally a nice process where you've got kind of a shared responsibility. When that patient's originally trained, they need to be set up and connected to your clinic accounts, however that works at that time. And then you actually ideally would document that in a shared space of how that patient is connected or if they're connected. And then other staff. And so that first step is really more, geared for your trained pharmacist or diabetes educators. And whereas the device download really can be done by any number of nurses or medical assistants, educators, and pharmacists. Next slide. And so the way I would qualify the types of data that you can obtain is just illustrated here. So it used to be that we were mainly relying on glucose logs. Maybe the patient faxed them or uploaded them to a portal between visits. And the success rate there is very low. I'm sure that anyone would know if they've tried to get glucose data. Moving up the hierarchy, downloading the devices on their own. We used to do that before we had a lot of app-based management. And so that was hit or miss, really more technologically savvy patients only. And with the last 5 years or so, now we have the ability for patients to put an app on their phone. And again, that's device dependent, where they can connect that app to a clinic account. The last step is really more of a wishful thinking, where you have a device that's connected to the EMR. Where we're going to be seeing our care leading is a device that links to some sort of intermediary service that then actually downloads data onto the electronic medical record. And so that technology is currently available. There's availability with Epic, particularly within the Apple Orchard, but it's still not widely available. Next slide. In terms of the benefits of telehealth. So multiple types of telehealth interventions have been shown to improve multiple dimensions of healthcare, including A1C. And this is an example of a systematic review. And they actually looked at different aspects of these telehealth interventions. And the two items that I will call out here is that the availability of mobile transmission of automatic transmission of data was a strong predictor of reduction in A1C. And also real-time feedback as opposed to asynchronous feedback. So that fits very well with the telehealth model. Next slide. In terms of other kinds of cardiovascular risk factors, again, few studies when we're looking at specifically telemedicine versus in-person visits. However, there's one systematic review that I've referenced here that did show that it was at least not inferior to in-person visits for a variety of different cardiovascular risk factors. We will leave it there and welcome any questions.
Thank you, Kathleen, and thank you, Kelsey. I just wanted to raise, excuse me, somewhat of a peripheral issue and that we're tackling now in our health system. In our family medicine department, 50% of appointments are no-show appointments. It's comparable in our medical obesity treatment program. In pediatrics, it's 60%. And in some environments across the United States, especially in poor communities, it's 80% of children not showing up for their appointments. There was a recent study that showed that among, for the problem specifically of diabetes, that in terms of attendance at appointments, telemedicine can reduce or eliminate racial disparities in attendance. And I'm not sure what exactly is going on, but it's interesting that the younger patients, the more tech-savvy patients, are more likely to no-show in person. So I think that we have to think of telemedicine as a bridge to something much greater in terms of engagement of patients as well. So beyond its advantages, I think that's a very important one.
Yeah, I think we've observed that, yeah, those younger patients are so savvy in using all of these devices. This comes more naturally to them. Okay, thank you. Any other questions for Kathleen or Kelsey before we go on?
No, this is Dana, and I'm sorry, I'm having some problems with my computer today, so I don't have my camera on, but this is just actually research that I've been involved in. It hasn't been published yet, but it's been just been analyzed. It's a Black students in counseling, and it's not related to diabetes, but it is definitely related to telehealth visits. And we found some mixed results. And actually, that surprised me that more college students actually prefer in-person visits because of the confidentiality issues. And as was pointed out in the presentation, that that feeling personable, and feeling like you're really connected to your provider. So it's just interesting to see how things shift depending on which population we're talking about.
Yeah, it's a great question, a great point in it. I think a lot of people would prefer in person, but if you ask someone at the last minute, hey, you've got an appointment in an hour, would you like to convert it to a telemedicine appointment, which is what I think they do in a lot of studies. I think the answer is yes, I can still attend, I can still get something out of it. But yeah, I think most people do prefer to be in person, regardless of their age or other characteristics.
This is Karen. I just want to say one thing briefly. I wonder about too the flexibility and the power of just allowing for combination. So with the DPP, sometimes I have people or DSMES, and we have multiple visits. Sometimes they just want to see you in person, maybe even just the one time initially, and then telemedicine after that is fine, or it might be a combination. So I think combinations sometimes might be really, really helpful and flexible.
That's a good point. Okay, all right. Thank you very much. Great case, Amber. Back to you, Claire, for a moment.
Thanks. So as a reminder, you can always watch recordings on the Cardio website. Next slide, please, Rick. The next cardio webinar is in 2 weeks on the 22nd. Ben O'Donnell from Ohio State will be talking about the intersection of weight management and diabetes care. We do encourage you to join and to pass along to your networks. I have a specific flyer if anyone's interested, just let me know. Next slide. Post-clinic survey should have been sent to you about 15 minutes ago. Please just take a moment to fill it out, give us some feedback on today's presentation. And then case studies. So we are a little bit short on case studies. So if anyone wants to submit another one, please let me know and I can send you a link. And if I am missing your case studies, please submit those so we can get them scheduled. We will see you guys next week.
Thank you, everyone. Have a great week. Bye-bye.